Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started. Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. I am your host, Erika Mayall. Before we get started on today's podcast, just a quick reminder, if you have not yet liked or subscribed or left a rating or review for the podcast, I would really appreciate it if you take 2 seconds right now, just go and hit that 5-star button on whatever podcast platform you are listening on. All right, we are going to dive in. Today, we are going to talk about Osgood-Schlatter's disease. And this is one of these conditions that I really wish had a different name, because I think that name, Osgood-Schlatter's disease, makes it sound like something fairly scary. And as you'll hear, this condition generally or does affect children and teens. And so if somebody, an 11, a 12-year-old, a 13-year-old gets this diagnosis of Osgood-Schlatter's disease, it often is very jarring and quite sort of anxiety-provoking and kind of scary for people to hear these words. But as you will see, it is not as scary as the name may suggest. So we're going to dive into all things Osgood-Schlatter's disease. But like I said, I kind of sometimes wish this had a little bit of a different name. In terms of podcast topics, sometimes I do episodes based on requests. A lot of times I do episodes based on requests. People will reach out to me or write in and ask me to cover a specific topic. And sometimes I end up picking a topic based on things that I'm seeing in the clinic. And anyone who's a clinician who's listening to this will know that things tend to often come in like waves or sort of little cycles. And you can go ages without ever seeing a condition and then all of a sudden see a whole bunch right at once. And that has been the case for me in the clinic in the last little bit. I have seen sort of a surge or a little bit of like an uptick in Osgood-Schlatter's. And I hadn't seen anyone with it for, like I said, months probably before. And all of a sudden it feels like every second person walking through the door is presenting with this. So I figured it was time to do a podcast episode on it. So what is Osgood-Schlatter's? It is essentially inflammation of the growth plate that occurs at the tibial tuberosity, which is the little knobbly bit at the very front of our knee, just below the kneecap area. So this is a condition that affects the knee. It's an anterior knee pain condition, and it is essentially inflammation of where the growth plate is on that attachment site. In more technical terms, it is a traction apophysitis. You don't need to know those technical terms necessarily, but just know that it is a condition that affects the growth plate at the front of the knee. I have done a podcast episode on growth plate injuries, a more general just growth plate injury episode. It is episode 28. I will link it in the show notes if you're interested in other growth plate type issues, but we're going to focus specifically on Osgood-Schlatter's today, which is that growth plate right at the front of the knee. And it is the site, so that tibial tuberosity is where our patellar tendon attaches into our shin bone, our tibia in through there. And so in active teens and children, we will often see some irritation or inflammation where that patellar tendon attaches in because they're using their quadricep muscle so much. So this is definitely a condition that we see much more in active populations, not just in dancers necessarily, but in other kids and teens who are doing a lot of sports that involve running or jumping or things that have sort of repetitive strain on that quadricep muscle in there. Our growth plates are not as strong as fully mature bone or solidified bone. So our growth plates actually start out as cartilage, and then as we grow and as changes happen in the growth plates, they actually solidify. But that growth plate itself is not as strong as other bony attachments would be. So it is an area that is susceptible to injury, and especially kind of a repetitive strain type injury where if there's something that's pulling, so in this case, the patellar tendon is pulling on that tibial tuberosity or the growth plate at that tuberosity a lot, it can cause these inflammatory reactions. We will sometimes also see inflammation in the patellar tendon as well, where it attaches into that site, but it's actually the tendon itself that can become inflamed. I would say that is less common. More often than not, when I see Osgood-Schlatters, it is isolated to the bone and to the growth plate in that area and doesn't necessarily involve the patellar tendon itself, but in some cases, we can also see it affecting that tendon where it attaches into the tibial tuberosity. So, like I mentioned, we see this in children and adolescents. And the reason for that is because it has to do with a growth plate. And so we have to have growth plates present for this specific condition to be presenting itself. So if we have a mature dancer who has anterior knee pain, it could be located in a similar area, but they are likely going to be given a different diagnosis. It's more likely in a skeletally mature dancer that we are going to see a patellar tendinopathy or even a patellar tendinitis, or we may actually see sort of an osteochondritis in that area, but that is more related to the actual like solidified bone. So it's going to present slightly differently. So in true Osgood-Schlatters, because it has to do with the growth plate, it is affecting adolescents. And then, like I mentioned, it is much more common in active adolescents. So especially activities with running and jumping and things like that. Interestingly, it is much more common in boys than it is in girls. And that is across the board. Like all the research that's ever been done on it shows that it's more common in boys than girls. And I don't know if we know exactly why that is, but I wonder if they actually controlled for activity level, if we would still see the same trend. Because I think at least historically, and probably actually the data even shows nowadays, adolescent boys tend to participate in activity at a higher rate than girls do. And so that could be contributing to one of the reasons why we see it more commonly in boys than in girls. There obviously could be lots of other factors that affect that as well. And so I'm not saying that that's the only thing, but I do wonder, I'm not aware of any studies that have actually looked at, and they may exist, I've just not dug into it, but looked at matching boys and girls for activity level and then looking at rates of Osgood-Schlatters and to see if it's potentially like more similar distribution or if we still see that higher prevalence in boys. And generally, in terms of onset, we are going to see this happening right around that adolescent growth spurt is when we most commonly see it. So in girls, the most common kind of onset or ages, we often see sort of 10 to 14, 11 to 14, somewhere in there. And then boys maybe slightly older, sort of like 12 to 15-year-olds, although a lot of the literature even still says like 10 to 15-year-olds in boys as well. In terms of prevalence, you see some pretty varied numbers in the literature about how common this occurrence is, and some of that has to do with, looking at the difference in rates in boys versus girls. But on average, the prevalence is about 10% of the adolescent population. But then, like I said, that increases if we break it down into active adolescent populations. And so then some of the literature is showing upwards of like 33% in more active populations. In terms of looking at prevalence in dancers specifically, I had a harder time finding research that really specifically looked at rates of Osgood-Schlatters. There are lots of studies that looked at anterior knee pain and then breaking down the different causes of it. And so sometimes it shows up in that research. But in terms of studies that were specifically looking at Osgood-Schlatters, I couldn't find a ton necessarily. But there is one study on modern dancers, and it sort of said 2.8%, or a study of Irish dancers that was at 5.8%. So these rates are not massively high. Like we're at that sort of under 10% threshold. And again, I don't know how much of this has to do with the male versus female distribution, because we know that dance is participated in predominantly by females still, or there is a larger proportion of girls participating in dance than boys. And this is a condition that tends to affect boys more than girls. So our rates, like I said, are not super high, but we certainly do see it. And part of that is that sort of repetitive nature of quadricep activation in dance that exists similarly to other sports. So we may not run as much in dance as, maybe soccer or basketball or something like that, but we have that like landing and jumping and even deep grand pliés, like those types of mechanics that are common. So how does Osgood-Schlatter present? How do we know that this is what is going on? One of the hallmark signs or features of it is that tibial tuberosity in the front of the leg will actually get enlarged a lot of the time. And so in the beginning, it could start by looking more like swelling in the area. And so it gets quite swollen. It might get red. There's signs of inflammation. But if you look at the front of both legs, one of them will look like it's like much more prominent, or it's like protruding a little bit more in through there. So that enlarged tibial tuberosity is one of the hallmark sort of signs. It will then almost always be quite tender right on that tibial tuberosity. So if you press on it, it's like really, we call it kind of like exquisite, like tenderness or point tenderness. That again is a hallmark sign. That being said, if the growth plate is going through a phase where it's not metabolically super active, it could be less tender in that area. But dancers will always sort of say, yeah, that's the spot that before was like really, really sore if you pressed on it. And right now it's not that sore. So it is really common to have fluctuations in how tender or how sore it is in that area. But it's always going to be pretty specifically right on that tibial tuberosity. Other knee issues, especially anterior knee pain, if we're having issues with something like, say, patellofemoral pain syndrome, it's usually a little bit more vague. People will say, I don't know, it's just kind of like the front of my knee, mostly the inside, but sometimes it goes, and they're not going to be able to pinpoint it quite as well. But with Osgood-Schlatters, it's almost always like this exactly right here is where it hurts. Like I said, swelling and potentially redness as well in that area. And then one of the other things that we hear pretty much across the board is kneeling is one of the things that bothers people the most. And again, it's pressure directly on that tibial tuberosity that is oftentimes people can't tolerate it at all. So that is another very sort of key hallmark sign of Osgood-Schlatters. In terms of addressing this, what do we do? What is the treatment for it? Because like I said, this term, especially Osgood-Schlatter's disease, makes it sound, like I said, very scary. So what do we do about it? And the one sort of thing I will always tell dancers and their families who come in with this is what we term a self-limiting presentation or a self-limiting diagnosis. So if we did absolutely nothing about this, we just ignored it and pretended it wasn't happening, we didn't treat it at all, it will get better. It will eventually go away. And the reason for that is that, like I said, it is an issue with the growth plate. And as we continue to grow and as we continue to mature, those growth plates will eventually become less metabolically active, and they'll actually, solidify into solid bone. It's not as simple as that, but I'm going to just use that terminology. And when that happens, they generally become asymptomatic, and most people don't have pain associated with it any longer. There is a very small percentage of people who will have ongoing issues even after they've reached skeletal maturity. And in those cases, I suspect the people who are having those ongoing issues, it often probably has more to do with the fact that the patellar tendon may have become involved, because the patellar tendon could continue to be an issue. But most people, if they're just having the inflammation in the growth plate and there is no patellar tendon involvement, this problem is going to resolve itself on its own when you stop growing or when your skeleton kind of matures. That being said, depending on how old somebody is when they present with this, if we have a 10-year-old presenting with Osgood-Schlatters, that could be years from now by the time it sort of self-limits or recovers on its own. So there are things that we can do and that we want to do to help to improve the symptoms and really decrease the pain and discomfort while a adolescent is dealing with this condition. So number one, what we're looking at is activity modification. And we do not need to stop activity altogether. This is a question where a lot of people are like, do I have to stop dance? Do I have to? Like, people, again, are fairly anxious or concerned about that. And that is not the recommendation anymore. I'm going to call it the old days, but in the past, there was maybe a bit more of a conservative approach to how we dealt with Osgood-Schlatters. And so they would often put the kids in a cast, like cast their leg in a straight position so that the quad couldn't pull on that tibial tubercle, and they would leave them casted sometimes for super long periods of time. And we now know that the consequences of being immobilized in a cast are actually way more detrimental than continuing to allow some levels of activity. So we don't use any of those approaches anymore in terms of like casting and things like that, but we do modify activity. So in dance, the activities that tend to be the most aggravating are jumping, deep knee bends, so potentially grand pliés or things where you're doing transfers like on and off the floor. And then, like I said, kneeling, so direct pressure over that tibial tuberosity. So those are the activities that we may need to modify if a dancer is dealing with this. And we modify these based on pain tolerance. So this is different than an injury, say a muscle injury or a tendon injury, where we want to be really particular about how we're loading things in a really systemic way. And so our modifications might be based on that. In the case of Osgood-Schlatters, we are modifying based on how much pain or discomfort that dancer has at any given time. And because there is a relationship between the metabolism of the growth plate and how much active inflammation is in there, like I sort of alluded to before, it is not uncommon for Osgood-Schlatters to go through sort of cycles. And so there can be periods of time, and it could be a few weeks or even like a month or two period where it's much worse. So they have more pain, there's more inflammation, there's maybe more swelling, all of those things. And then it could go through a cycle of a few weeks or a few months where it feels relatively okay. There's minimal pain. They can kind of do all of their activities. And so when we think about activity modification, we just follow the sort of pain tolerance. Now, that being said, we have to have a lot of conversations with dancers about listening to our body, because dancers are sometimes just told to push through the pain, or they've been trained to kind of ignore these signals and these messages from their body. And so in this case, we can sort of say, you can do as much activity as you can within pain tolerance limits. And I'll usually give dancers like parameters within that. But we have to be really clear about listening to the body and not ignoring some of those kind of pain signals. And so that can be the tricky part of this, because it's not so much a activity modification based on progressive loading principles or anything like that. So activity modification is number one. Number two is we will sometimes use anti-inflammatory type modalities to try and address and decrease the inflammation in that growth plate. So in the clinic, that could be things like, depending on where you're going for physical therapy, if they have ultrasound machines or laser or red light or shockwave or any types of those modalities, those can sometimes be very, very helpful to help to reduce the active inflammation and therefore reduce some of the pain that is occurring. Less successfully, I would say, and not to say that we can't try these things, but using a like topical anti-inflammatory, say an anti-inflammatory cream or gel or things like that, that is often prescribed by doctors in these cases. I will say my clients with Osgood-Schlatters often don't have a lot of success with this, but everyone is different. So again, we can look at potentially trying something along those lines. So we want to try and modify the activity. We want to control the inflammation to the best of our abilities. We will often use ice in this condition, and if you have listened to any of my rantings and ravings about the ice versus heat debate and all of the research that's come out with regards to that, in the case of Osgood-Schlatters, we are using ice more as pain control than anything else. So again, the evidence in terms of controlling inflammation is probably not there, but with this condition, if people are going through a phase where it is sort of like actively painful and we're just looking for pain management and pain control, ice is often very, very effective in Osgood-Schlatters. And so we will often educate on, okay, you can use ice just for 10 minutes at a time. It doesn't have to be a long period of time, but especially after activity. So if you've gone and danced and it gets a little bit more sore by the end of dance, put some ice on it for 10 minutes, and that often will calm it down from a pain control perspective. So we will still often recommend ice in Osgood-Schlatters, whereas in other conditions, we're often not recommending ice. But at least me clinically with this from a pain management perspective, I am still using it because I found it to be effective with my dancer clients. And then from a more kind of physical therapy or like looking at the sort of bigger musculoskeletal picture around it, we want to try and make sure that all the muscles that influence and impact the knee are functioning in an appropriate way. And one thing that we very commonly see is we will see a lot of tightness in the quadricep muscle in people presenting with Osgood-Schlatters. And so that is something we definitely need to address, because the tighter the quadricep muscle is, the more tension it is going to put on that tibial tuberosity when the quadricep muscle has to contract. So the more quote unquote relaxation, that's not really the right word, but the more length we have and the more pliability we have in that quadricep muscle, the more we can offload some of that sort of like traction type tension that is being put on that tuberosity. The tricky part with this is that a lot of traditional quad stretches, so if you imagine just that standard run, I call it the runner's quad stretch, but you know where you're standing and you just pull your foot towards the back of your hip so that you're stretching the front of your thigh. Those types of stretches are often not easily achieved in people who have a lot of anterior knee pain, because it just puts more pain or pressure through that tibial tuberosity without necessarily getting a good stretch in the quadricep muscle itself. So oftentimes we're looking at maybe starting with things like foam rolling or even massage, or things that are we can help to loosen up the quadricep muscle, but without putting too much tension on it while we're stretching it. And then another stretch that I will commonly use is what in the physio world we call a modified Thomas test, but it is a stretch where we're sort of hanging off the edge of a table or a counter or something like that. And it's a stretch we commonly use for the hip flexors, but you can actually stretch the quadriceps in this position quite well as well. And you can often do it with less degrees of knee flexion. So sometimes this is a more accessible position to dancers who know that their quad is tight, but they can't actually do a lot of the traditional quad stretches without getting a lot of pain in that tibial tuberosity. So we definitely want to look at muscle length for specifically the quadriceps, but we're going to look at any muscle that attaches and influences the knee. So we're also going to look at hamstring. We're going to look at gastrocs. We're going to look at all of those muscles, but more often than not, it is the quad that's going to affect this. And then we're, of course, going to look at muscle strength and balance in, again, all of the muscles that surround and support the knee. So similar to what we would look at with any other type of anterior knee pain. So we're looking at core and pelvic control. We're looking at quads. We're looking at hip flexors. We're looking at the lateral hip stabilizers, all of the above. I will say, in Osgood-Schlatters, I less frequently see significant muscle imbalances around the knee. And what I mean by that is this tends to be an issue that if we're looking at addressing more global things, quad tightness is very common, but I often don't see as many weaknesses or imbalances compared to some other knee presentations like a patellofemoral pain syndrome, which almost always there's things above or below in the kinetic chain that we need to address. I don't as commonly see that in Osgood-Schlatters. And maybe it's because we tend to see this in super active populations. I mean, I don't know if that plays into it, but it is less common that we have to correct a lot of biomechanical things above and below. That is not to say that we don't ever have to. We certainly do, but I will just say less commonly so. Like, it is more common that I will assess everything, and everything else actually looks quite good, and it is much more of a local issue. So just throwing that out there. I don't know if other clinicians have had the same experience. And like I said, there are certainly kids that we do have to address that. And in the kids that we do have to address that, it probably does tend to be the ones who've gone through like periods of really rapid growth. So they've had a big rapid growth spurt. Then we might be more likely to need to address some imbalances that may have developed. So just throwing that out there, that is, of course, going to be our next step of treatment, but it's going to maybe look a little bit different than in some other presentations of knee pain. And then finally, we're going to look at protecting the knee. And so, like I mentioned before, direct pressure on the front of the knee or the front of the shin bone on that tibial tuberosity is often very, very, very painful. And so we always want to look at padding and protecting it. And so this is a population of dancers where I'm always going to recommend that they're using a knee pad for anything floor work, kneeling, anytime they need to have direct pressure on the front of that knee, we're going to recommend them using a knee pad. And I often recommend like a thicker knee pad, so more a volleyball style knee pad, as opposed to, I do know some of the dance brands now make kind of a more sleek, streamlined dance knee pad that is designed to, be able to go under costumes or just be a little bit more sleek, but they're not as thick. And so in the case of Osgood-Schlatters, I'm often recommending just a volleyball style knee pad that is a thicker, more padded one, because in this case, we really are just looking at padding that area and making it tolerable if possible. There are some dancers who, even with a knee pad, it's still too painful to kneel on, in which case we're just modifying that out completely. And so they might be avoiding kneeling. But for some dancers, having it padded enough then allows them to be able to kneel on that. So definitely looking at padding the area. And then some people do respond well to using a patellar strap. And these patellar straps are designed for a patellar tendinopathy. And again, like I mentioned, some people have inflammation or irritation in the patellar tendon, in which case they might respond well to the patellar strap. But even in people who don't have any patellar tendon involvement and it's just the growth plate that is irritated, even those people sometimes benefit from that patellar strap, because the idea of the patellar strap is that instead of all of the force being transmitted from the quad into the patellar tendon coming into one very specific area, so it's quite a concentrated area of load transference, the patellar tendon is designed to sort of dissipate that load a little bit more. It kind of makes the load occur over a larger surface area, if that makes sense. And so that can sometimes decrease how much pull there is on that tibial tuberosity. So sometimes we will experiment with using a patellar strap in these cases as well. However, if they're already wearing a knee pad, it can become a bit cumbersome, and we're not going to do a patellar strap and a knee pad at the same time. So it really depends. But if you have a dancer who's dancing in a style where they're not on their knee, like say we have a tap dancer, and this can be fairly irritating in tap because you're, doing so much repetitive lower leg movement, they actually might benefit more from a patellar strap over a knee pad versus a contemporary dancer who might be doing a lot of floor work. They're going to benefit more from a knee pad over a patellar strap. So that being said, just we want to look at how can we protect the area while it is sort of inflamed and irritated at the time. All right. I think that's all. Oh, actually, one thing I do want to say, I was going to say, that's all I want to say. One thing I will say is the majority of people who get Osgood-Schlatter disease only get it on one side. And so this is a question that often comes up from parents or even from the dancers in the clinic is, oh, well, am I going to get this on the other side now? And it is a small percentage of people that get it bilaterally. And the people who get it bilaterally, it's not usually at the same time. So sometimes you will see people who have it on one side, and that maybe resolves within a period of time, say 6 months, a year, 2 years, whatever it is. And then they'll start to get it on the other side. But like I said, that is very uncommon. The much more common scenario is that dancers will only ever have it on one side, and then it eventually goes away, and then they don't have any issues again. So I just wanted to mention that. I meant to mention that at the beginning when I was talking about sort of what it is and the prevalence and stuff, but I forgot to mention it. So yeah, it is a condition that we generally only see unilaterally. So there you go. I think that's all now that I want to say about Osgood-Schlatters. If you have any questions, please feel free, reach out, let me know. Happy to answer them. And I hope that that has been helpful for you or anyone you know who has been dealing with it. Once again, thank you so much for listening, and I hope you have a great rest of your day.